Okay guys, Miss Hill here, and we are going to talk about individual module 9, which falls under the concept of infection. We're going to talk specifically about conjunctivitis and acute otitis media, and then talk about a few other communicable diseases towards the end of this PowerPoint. So here are your learning outcomes for both otitis media and conjunctivitis. So what is conjunctivitis? You can see some pictures here of what conjunctivitis looks like. Mainly what you see here is bacterial conjunctivitis. And conjunctivitis is a highly contagious and transmittable disease that happens through direct contact. So ineffective hand washing, use of other people's towels. Also, it can be transferred through vaginal discharges whenever a mom delivers her baby. And what happens in this illness is the conjunctiva of the eye, which is a thin membrane that covers the anterior surface of the eyelid, becomes infected with some type of microorganism. And that can be several different types of microorganisms. It can be gonorrhea, chlamydia, it can be staph, E. coli. It can be viral, such as the herpes simplex virus or the adenovirus. And there are some different types of conjunctivitis, 5 to be exact. We have bacterial, viral, fungal, allergic, and we can get conjunctivitis from different types of chemical reactions, either through exposure from the environment or through actually getting some type of chemical in our eye. With bacterial conjunctivitis, like in the previous slide, you see a purulent discharge, and that's sort of your main characteristic of the bacterial type. For a viral conjunctivitis, we usually see a serous or a watery discharge. And with the allergic type of conjunctivitis, you also see a watery discharge and sometimes a thick drainage, and it's normally pretty itchy. So what are our risk factors? Well, hand hygiene, definitely, since this is spread through direct contact. People who have poor hygiene in terms of their contact lens use and care. So those would be the people who sleep in their contacts or have poor hand hygiene before they put their contact lenses in. Contact lenses will trap on the surface of the eye whatever was on the inside of that contact prior to it being inserted, and so that puts these people at a greater risk. People who are immunosuppressed, as we know with any illness, are at higher risk for just about every type of infection. People who have traveled to certain places and people with risky sexual behavior are also at an increased risk for conjunctivitis. And in terms of this risk factor, think about the people who might get a viral conjunctivitis through a herpes exposure. So that herpes simplex virus can cause the conjunctivitis like we talked about in the previous slide. And that's why risky sexual behavior is listed here. So what do we see? Typically the eye is red with a characteristic discharge, and it depends on the causative agent as to what type of discharge that you see. And we also see matting and crusting. With older kids, they'll complain of eye pain, or they'll complain of sensitivity to light, which is also called photophobia. And we can also sometimes find that the eyelid will actually inverse, which is called entropion. Gonorrhea is another causative agent that will lead to conjunctivitis of the bacterial type, and oftentimes you see this in newborns with a mother who has delivered vaginally and has not been effectively treated for gonorrhea. And what happens in gonorrhea with a gonorrheal conjunctivitis is that the cornea of the eye will actually perforate to cause that blindness. So with the bacterial type of conjunctivitis, we said our main clinical manifestation is going to be that purulent discharge, that pussy, nasty looking discharge. But these people also have redness, burning, they have irritation, maybe a sore throat because having an upper respiratory infection can put you at a greater risk to get conjunctivitis. They might complain of photophobia. You might see swelling in the eyelid. They might have matting of the eye upon waking up. And a lot of the times, the bacterial conjunctivitis is only seen in one eye, so it's unilateral. With the viral type, the type of drainage we see is that serous, watery type of drainage. But these people still have the redness and burning, irritation, potentially that sore throat, photophobia. And usually when we see the viral conjunctivitis, we see it in both eyes, so bilaterally. And we are going to watch a quick video about conjunctivitis, which people also call pink eye. And this is a live diagnosis by Dr. Paul.
At MD Anderson, we're making cancer history.
Hi, it's Dr. Paul. You're about to see a visit for a whopping case of pink eye that involves just one side. You're going to see the visit, and then I go over it in detail at the end, so stay tuned in. So what brings you in today?
Well, I think Elliot has pink eye.
When did this start?
Just this morning, woke up with that bright red eye.
Well, let's take a look. I'm guessing you're Elliot. Is that right?
Yeah.
How can I tell? You're the guy with the eye. You know, what's interesting, so he went to bed last night and he was fine.
Perfectly fine, yes.
And woke up with this.
Yes.
And has he had any discharge from this eye?
Mm-hmm.
He has. He looks happy.
Yeah, pretty happy.
No fever?
No fever.
No fever. And has anybody else been sick?
No.
Okay. Could anything have gotten in his eye by any chance?
No, I don't think so.
Okay. It's very interesting. So, let me take a look at him. Just check out the rest of him, because sometimes with pink eye, when you have younger children, you know, less than 1, 2, or 3, there'll be a 50-50 chance that when you have a pink eye, you'll also have an ear infection. That ear looks perfect, and this ear looks perfect. And let's see your throat. Say, ah. Your throat looks perfect, too. Stick your tongue all the way out. Very nice. It's interesting for purposes of training. If you look at this eye, let's zoom in on this eye. There you go. Compare it to the other one. We've got one eye that's perfectly white. The sclera is the white part. When the sclera is red, if that was red on both eyes, we'd be concerned about possible Kawasaki's disease or mucocutaneous lymph node syndrome. That can be serious, and the telltale sign is that the whites of the eyes are both red. And often there's a fever for a few days, high fever, a rash. You can have lymph nodes in various places, which tickle, you don't. And the tongue can be really strawberry. They call it a strawberry tongue. He clearly doesn't have that, but that's one thing for educational purposes. You don't want to miss that. Because this is discharge and so inflamed. Now there's two kinds of conjunctiva. The lower lid there is called the palpebral conjunctiva, and the white of the eye, that in this case is red, but over here it's white, is the bulbar conjunctiva. So with run-of-the-mill mild pink eye, the white of the eye usually isn't that effective. It's more just the lower part. So you got a good one. I think you should be a celebrity on YouTube. What do you think? You think so? Because you got the perfect eye. You're going to teach millions and millions of people what regular pink eye looks like. So we're going to give him an antibiotic eye drop. You'll go ahead and put a drop in each eye 3 times a day until it's all better, plus a day. Usually it's 5 to 7 days. There's numerous ones that can be used. from gentamicin, tobramycin to the siloxane, ciprofloxacin drops. There's many. And so we'll just get him a good one. He'll get better. And if he doesn't, obviously, come back.
Great, thank you.
Right? So, what do you guys think? Oh, you were telling me something at the beginning. What was it? How do we know he's got a problem?
It's red, it's itchy, and it has this goopy stuff.
Perfect. Now, if it was just red and itchy, it probably would be allergies, especially if it was equal on both sides. But since this has goop and it's clearly on the one side, this is pink eye. And good work. Thank you so much for helping the world know about pink eye. And thank you for watching. I'm Dr. Paul. His particular pink eye is unique in that it's so one-sided, but it's illustrative of pink eye in a very extreme form, and it happens to be only on one eye. It's usually two. So this should be instructive. This particular video, we just showed a quick overview of the exam. Obviously, I did a complete history and physical, and I wanted to wrap it up by explaining a little bit more about the causes of pink eye. I mentioned in the video that it can be allergic, but when it's an infection, it's most often viral or bacterial. The bacterial pink eye is the one that most often has a lot of goop in it and thick discharge. That's the kind of pink eye you're going to want to treat with an antibiotic eye drop. Viral infections don't need antibiotics. They're going to get better. They tend to be bilateral, both sides, just like the allergic pink eye tends to be both sides, and they both tend to be milder. An allergic pink eye will just have sort of a watery discharge. It won't have the thick pus, purulent discharge that you see with bacterial pink eye. So, thanks for watching. I'm Dr. Paul.
Okay, so that was the video from Dr. Paul, and it was a live diagnosis of conjunctivitis. So we're going to move on to nursing diagnoses related to conjunctivitis. And here are 3 good ones. Infection related to whatever pathogenic organism is causing the problem. Social isolation related to the infectious process, because these children can't go to school until after they've had a certain amount of antibiotics or until after their symptoms clear up. And a risk for disturbed visual perception. They have photophobia, so they don't tend to want to open their eyes. They want to be in a dark room. For those kids with the gonorrheal conjunctivitis or the babies born with that, they may end up with the corneal perforation and end up with blindness. Also, we can think about risk for infection for those who have close contact with someone diagnosed with conjunctivitis, impaired comfort, and readiness for enhanced knowledge, especially if we have maybe a contact user who's a new contact user and we need to educate them in regards to hand hygiene and how important it is to keep their contacts clean and not sleep in them and those types of things. So what do we do as nurses to intervene? Our focus of care is geared towards prevention, towards people transmitting it from one person to another, and to prevent self-limitation of transmission from one eye to the next, especially if it's bacterial. We want to resolve the infection at hand, and we want their symptoms to be relieved. And if they have to take any type of medication, then we want them to comply with whatever that order might be. So if it's an antibiotic for a certain number of days, we want to make sure they take it completely. Specifically for bacterial conjunctivitis, these people are going to get antibiotic drops or ointments. And we can encourage warm cloth compresses. That helps aid the removal of any crusts that might form in the eyes. We want to instruct them to remove the discharge, avoid bright lights, make sure they have good hand washing, and cool compresses can help relieve irritation if they have itching or those types of things. For the viral type, they might get antiviral drugs, but only if the causative agent is herpes simplex virus. For the other viral types of conjunctivitis, so let's say somebody has just had an upper respiratory infection that was a viral infection, and now they have conjunctivitis related to that URI, those people are not going to get any type of antiviral drugs. We only give the antiviral drugs to the people who have conjunctivitis related to herpes. We can also encourage cool compresses, avoiding bright lights, a removal of the discharge with a wet cloth, and good hand washing for the viral type as well. So for your question down at the bottom, what would be the teaching interventions? Whoa. Went a little fast there. Sorry about that. So for that question down at the bottom, what would be the teaching interventions for the parents of a child with acute conjunctivitis? Well, we just said a lot of them. One thing we didn't say was that we need to teach parents to clean the proper way whenever they're cleaning the eye, or if they're using those warm cloth compresses to aid the removal of crusts, they need to know that they should be cleaning from the inner eye to the outer eye. So we're going to move from the cleanest spot to the dirtiest spot. And we want to make sure that they understand what good hand hygiene means. Many people don't understand that. So we want to teach them hand washing techniques. We want to make sure that they understand not to share towels through the family. And that parents don't send their children back to school until 24 hours after an antibiotic therapy has been started if it's a bacterial type. For babies and younger children, we might encourage parents to use mittens on their hands so that they can't self-contaminate from one side to the other. And we need to teach them how to administer eye drops if they're prescribed. For the newborn or the neonate who's in the hospital and you're caring for them and they have conjunctivitis, these babies will be on isolation, because the last thing we want is to transfer that to other newborns on the unit. So we'll isolate these babies. Specifically in relation to drug therapy related to conjunctivitis, you're going to see anti-infectives used. They can be topical, oral, or systemic. Antivirals, but only for the herpes simplex virus. Mast cell stabilizers or antihistamines. You might see topical steroids or vasoconstrictors used, possibly decongestants. And artificial tears may be something we recommend for cleaning, like normal saline for cleaning some of the discharge out of an eye. So if we have a bacterial conjunctivitis, some examples of drug therapy that you might see ordered are penicillins, gentamicins, erythromycin, and bacitracin are a few of your broad spectrum ones. For the viral type, you might find acyclovir, but only for the herpes. For gonorrhea, if we have a mom who has gonorrhea and the baby has been exposed to that, Rocephin is the drug of choice there. And for chlamydia, an oral erythromycin or a tetracycline is normally used. So what we expect is that the eye returns to normal. We want it to look normal and we want it to function normally. And that's it on conjunctivitis. Now we're going to move into otitis media. And so what is otitis media? Well, it is an infection of the middle ear. And you should remember from anatomy that ear infections, or the ear has 3 different chambers, right? We have the external ear, we have the middle ear, and the internal ear. So we can actually have an ear infection in one or more of those chambers. So we can have an otitis externa, which is in the external portion of the ear, and that's oftentimes called swimmer's ear. Or we can have otitis media, which is the one we're going to talk about today, which infects the middle ear. And when things get really bad, we can end up with an otitis interna, which is on the internal space of the ear. And sometimes we hear this called labyrinthitis. This is the most common childhood illness and the greatest reason for unscheduled doctor's office visits in the United States. It's very common in children who are 5 years or less. And what we know about the middle ear is that the tympanic membrane is that little piece in the middle ear that protects the middle ear from the external environment. And then we have eustachian tubes that connect the middle ear to the nasopharynx. And so what we have is a route for infection from the nasopharynx into the middle ear through the eustachian tubes. So if you think about that, people with upper respiratory infections, often you will find, especially with children, that they will end up with an ear infection after they have had some type of upper respiratory infection, a cold of some type. And that is because those eustachian tubes become inflamed and swollen, and they do not allow normal airflow or drainage between the middle ear and the nasopharynx. We also have 3 types of otitis media. We have serous, acute, and chronic. With the serous type, we find there's a prolonged obstruction in the eustachian tubes, and that causes a middle ear effusion, which means just a trapping of fluid in there. And if we trap fluid somewhere in a dark, moist space, then it can grow bacteria, causing some type of infection, or otitis media in this case. Most often what we see are acute otitis media episodes, and those typically follow your upper respiratory infections. And then with chronic otitis media, what happens here is that we've had an ear infection over and over and over again, and that involves a permanent perforation of the tympanic membrane, and that can cause hearing loss. So we have to pay close attention to how many times children come into the doctor's office with an ear infection, because it can eventually affect their hearing. So we're going to watch a quick video.
Hi everybody, this is Dr. Efrat coming back to you with another case of otitis media. In this case there was thick middle ear fluid. It's called glue ear actually. So we use topical anesthesia to again anesthetize the eardrum. The difference between this exam and this ear drainage and the prior one which I posted is that the middle ear fluid in this patient was very, very thick. And it's what we call almost a glue ear. The middle ear fluid is very thick and tenacious, and it causes a significant hearing loss. In this patient, it was ongoing for over a month, despite using allergy medicines, decongestants, and antibiotics. So a decision made was to drain the ear. And now when we suction out the fluid, you see that it's not just a watery fluid. You see how thick and tenacious it is. And there is such significant improvement in the hearing once this is performed. Again, this is performed endoscopically with a high-definition camera. The patient is awake. Once we've completed the suctioning process and the middle ear space is clear, the patient feels immediate improvement in hearing. We'll take another look closer with the endoscope, and then upon completion, we'll put him on antibiotic eardrops, and this incision should heal spontaneously. Again, it's performed in parallel with the fibers of the eardrum. Thank you.
Okay, so there you see actual drainage of an otitis media that had formed a really thick infection behind the tympanic membrane, and you saw him make that incision in the eardrum and suck all that stuff out. So what might cause these types of infections? Streptococcal pneumonia is one, the Haemophilus influenza, and Streptococcus pyogenes is another pathogenic organism that you might find with your acute otitis medias. When we have recurrent acute otitis media, we define those as 3 distinct episodes of otitis media in 6 months, or 4 distinct episodes in 12 months. And whenever I say distinct episodes, that just means they are separate infections. So it's not an infection we've had that just didn't improve with medication or symptom management. It's a totally separate infection from the first time. So who is at risk? Babies who are being improperly fed with a bottle, and you can see the picture here. This bottle is propped up, baby's laying down. That is definitely a risk factor for getting acute otitis media. Exposure to cigarette smoke, cross-contamination with other children or people, improper use of pacifiers, and that would be your children who use pacifiers for several hours during the day. Kids with a cleft lip or a cleft palate, and typically ones that have Down syndrome, also will be at risk because they have a dysfunction of their eustachian tubes. Enlarged tonsils or adenoids in people will also put them at a greater risk for acute otitis media. And allergies and daycare attendance are also another big one we see in children who present with otitis media. The peak prevalence for these ear infections are often seen between 6 and 18 months. And in 80% of the cases, the kids are 6 years or less. So it's typically an early childhood illness that you see. Breastfeeding tends to be protective against acute otitis media for the first 12 months. And the theory is that this is due to the presence of IgA that crosses through breast milk, and that helps protect babies against infection. So remember, that's your active antibodies. Mom has them already, so if she's breastfeeding the baby and they're transferred to baby through her milk, then the baby has those active antibodies. They don't have to make them themselves. Their immune system doesn't have to stress out to try to find a way to fight off a new infection. Mom has already transferred those antibodies over to baby, and it tends to protect them from all kinds of infections. But acute otitis media has been one specifically that it's been proven to help. So for children who are young, some things that we can do or teach parents to let them understand whenever it's important for them to bring their kids to the doctor's office to be checked out is for the younger kids, they will rub or they'll pull or tug on their ear because it hurts. They may have fussiness, not fuzziness. That is definitely a typo. So they may be fussy or irritable. They may cry and not be consolable. They may have poor feeding because that suck and swallow will actually cause pain. So they may stop feeding. You may find that they have a fever that is a high grade fever, 104. And they may have lethargy. For older kids, they'll complain of ear pain. They'll complain of having a lot of pressure or feel like their ears stopped up. They may complain of being dizzy or having vertigo or like, the room is spinning. That you might find that they're falling or they're running into things. So they have a disturbed balance because we know that our ears and the pressure there sort of helps us balance. They may have ringing in their ears, popping. You may find some fluid discharge. Sometimes it might be smelly. They may have hearing problems. So typically they listen to you pretty well, but now you're finding that you're asking them to do things and they don't even hear you, or you think they're ignoring you, but they're really not. They just can't hear you. And then if it goes on for long periods of time, you may find that their speech starts to change. For the younger kids, that irritability and crying often happen at night, and that's due to just their position, because as they lay down, the pressure in their ear will increase and cause them pain. So that's when you find that they're probably the most irritable and cry most often. Whenever you look inside the ear of somebody who has acute otitis media, you saw the picture of how the eardrum was kind of bulging out with the fluid a while ago. But you'll find that there's a decreased mobility of the tympanic membrane. You'll see the bulging like you did in that video. You might be able to see that fluid or air behind the eardrums. You might see bleeding, or it may appear red or yellow or pus-filled, and it may look swollen. Excuse me. All right, so here's just a little picture to look at, and this just tells you some of the things you may see with otitis media. So for the babies, you may see pulling at the ears, or you may see that nasty drainage like you see on that one side. They have that decreased appetite. They may have post-auricular and cervical lymph node enlargement, so you may find that their lymph nodes are enlarged whenever you do their exam. They'll have a decreased pain after their eardrum ruptures, if it does. And the reason they feed poorly is because sucking aggravates that pain. So for nursing diagnoses, we always think about acute pain in relation to otitis media because it is very painful, especially for children. All of that fluid accumulates behind the eardrum. It causes a lot of pressure and it hurts. Infection related to the invasion of whatever type of causative agent there is. Hyperthermia related to the fever. A disturbed sensory perception, specifically in relation to their hearing, but it could also be for balance, like we said before. Also, knowledge deficit, specifically parental knowledge deficit in relation to management of the disease. So maybe we have parents who are smoking around their kids who are having repetitive ear infections. Or maybe we have parents who are propping bottles or feeding their babies not in an upright position, but more laying down. So all of that milk is draining into their ear. So those people need education. There may also be risk for caregiver role strain because we have babies who are waking up in the middle of the night that can't be consoled. There may be a risk for delayed growth and development in relation to speech. And there also may be impaired verbal communication in relation to their speech. So how do we manage it? Well, first and foremost, we want to prevent it, right? We want to actually avoid the infection. We want to reduce or eliminate precipitating factors, exactly like I was just talking about, propping bottles, smoking around your children. And if we don't prevent it and we actually have a kid who gets it, then we do symptom treatment mostly. But we want to teach parents about positioning and feeding, ways to sleep. We might prescribe or the doctors may prescribe anti-infective drugs. And usually what you'll see are a treatment with antibiotics for 10 days in children under 6, and anywhere from 5 to 7 days in kids who are 6 years or older. For that serous otitis media that we talked about, we usually don't treat that with antibiotics because it's related to a dysfunction of the eustachian tubes. And so we typically treat that in a different manner. What are the preventative strategies for acute otitis media, and how can you alleviate the symptoms? The very first thing we do is administer antibiotics as soon as possible. And so in terms of drug therapy, what's the most current evidence-based pharmacological management of acute otitis media? Well, our first line drug is going to be amoxicillin. And if amoxicillin is not working, then what your doctor will go to is an amoxicillin with a clavulanate drug. And if the tympanic membrane is intact, you may find that the doctor will prescribe a topical anesthetic, and that usually comes in the form of a drop, and that will help with symptom management like ear pain and pressure. Another thing that we really want to encourage as well, going back to this drug therapy slide, is whenever we're talking about actually managing the disease in terms of prevention, we really want to encourage parents to make sure their children get the proper vaccines. So, for example, the flu vaccine would be very important because we know that upper respiratory infections are linked really closely with a following ear infection. So it's very important to encourage and educate on vaccines, especially for those children who have repetitive ones. So if they get very severe, then we may have to actually manage with surgery. And we do this with a laryngotomy, which is basically just the insertion of ear tubes. And this is indicated for that chronic acute otitis media and some of the following things: mastoiditis, to relieve severe pain, to drain fluid, which is what we saw in the video. And sometimes they'll do this to collect a sample of fluid for lab testing. For these individuals, one thing that we teach as nurses for aftercare is to avoid getting water in the ears while those tubes are in place. And we want to educate parents that those tubes will fall out around 6 to 12 months. And that's okay. They will fall out by themselves. And they just need to let the doctor know that the tubes have fallen out. They won't put them back in. They are meant to fall out on their own. And we're going to watch a quick video on toe placement. And so what you see here is that they are actually incising the tympanic membrane. There you saw him sort of suck out the little bit of bleeding that was occurring. Just made that incision a little bigger. And again, he's sucking out the bleeding. And also sucking out the fluid behind the tympanic membrane. So decreasing and relieving that pressure. And here's the tube. And there you go. He's inserted it into the incision. And it's as simple as that. So again, we want to educate parents that those tubes will come out on their own after about 6 to 12 months post being placed. So here's what we expect. We expect that the child will be relieved of their symptoms. We want them to be comfortable. We want them to receive their prescribed dose of medications, especially if they're antibiotics. So we want medication compliance. We want them to stop having ear infections. We don't want them to reoccur. We want their parents to be able to get some uninterrupted sleep and rest. And really, above all else, we don't want them to have any sensory deficits. So we don't want them to have any speech delays or any types of hearing difficulties that are lasting in relation to these ear infections. Okay. Moving on to Fifth's disease, which is a communicable disease. There are your learning outcomes, very few. And what is Fifth's disease? The other name for this is erythema infectiosum, and it's caused by human parvovirus B19. We know that you've probably heard of parvovirus in relation to animals, pets, dogs, and your dogs. Different types of pets get parvo vaccines. And this is not the same type of parvovirus. This is actually one that is only transmitted human to human. You can't catch this from your dog. But there are parvovirus illnesses that affect humans alone, and this is one. And what you find is you get this mild rash type illness, and it's often called slapped cheek syndrome. And you can see the little girl in the picture there where her cheek is kind of red. That tends to be what it looks like. And then later on, as the illness progresses, you get this lace-like erythematous maculopapular rash, and it becomes evident in other places on the body. We most often see it in winter and the spring, and we see it in kids that are anywhere from age 5 to age 14. It's usually transmitted through respiratory secretions or blood, and it has a fairly long incubation period, anywhere between 6 to 21 days. But most of the time, it's transmitted the week before you see any symptoms. So it's very contagious, and very easily transmittable because oftentimes we have already infected other people by the time we even see the first symptom in ourselves. Once the rash appears, it's no longer contagious. So here's that lace-like rash in the picture where you see there. There are 3 stages of Fifth's disease, and they all have different types of clinical manifestations. So in stage 1, you don't even see the rash. This is where you get flu-like symptoms. These kids will have a low-grade fever, a runny nose. They might complain of a headache. They may have body aches, and those usually last for about 2 to 3 days. And then from 1 to 7 days, they might be symptom-free, so they feel better. You've thought that they just had a little cold. And then in stage 2, which is about a week later, they get this slapped cheek look, that really fiery red rash on their cheeks. And with some children, you'll see a really pale skin color around their mouth. And then later in stage 2, between days 1 and 4, you find that lace-like, symmetrical, maculopapular rash on their trunk and their limbs, and it spreads in a direction of proximal to distal. So from the trunk out to the extremities. And the palms and the soles are not involved in this type of rash like you see in hand, foot, and mouth. Then moving on to stage 3, this is when that rash begins to fade. It might itch, and that usually lasts anywhere from 1 to 3 weeks. Complications might occur in children with Fifth's disease if they have some type of hemolytic condition, because they will tend to get arthritis and arthralgia. And it just has to do with their compromised immune system. So what do we do? Well, typically we don't do very much except relieve their symptoms. So we diagnose it through physical signs or possibly serological testing. And like I said, our treatment is aimed at symptom relief. It spontaneously recovers. They don't have to have any drugs typically unless they are having some type of serious complication. So if they are an individual who ends up in aplastic crisis, they might have to have a blood transfusion. Or for patients who have a decreased immune system, they might require some type of IVIG therapy. In pregnant women, it actually can be fatal. It can cause abortion. It can cause high drops for the baby, and it can cause fetal infection. And one thing we want to do is to really just prevent it. We want to avoid people who are infected, have really good hand hygiene, and really good respiratory hygiene. So for you as the nurse, you're going to make sure that you maintain standard precautions and droplet precautions if they're sneezing and, snotting all over the place. You see this little kid here in the picture, and he's rubbing his nose on his hand. If he is in that stage 1 of flu-like symptoms and he spends most of his time at daycare, and then he goes and picks up the blocks to play with those, and then another kid comes and picks the block up to play with him, they will probably end up with Fifth's disease just like he has before he ever even knows he's got it. We encourage parents to use non-aspirin antipyretics to keep the fever down. If the kids complained of itching, especially in that second stage where they get the rash on their trunk and their arms, oatmeal baths and antipyretics tend to be helpful in relieving symptoms. We want them to rest and provide diversional activities so they don't scratch all the time. Give them frequent fluids. And then we educate the caregivers on the stages of illnesses so that they don't think that the kids are getting worse. So for example, if you come in because the cheeks are red, or you come in because they've got these flu-like symptoms, and we discover that it is Fifth's disease indeed, we want to let them know that it's going to look worse before it gets better. We want them to avoid sunlight, have good hand hygiene, good respiratory hygiene, and there's not really any need for them to avoid normal activities. And you have to remember that with Fifth's disease, typically they are not going to transmit this illness. They're not contagious after the rash appears. So they really can go back to daycare at that point, although it's probably pretty scary for everybody else. So quick little video.
Fifth disease is a fairly common infection in children, characterized by fever, rash, and other symptoms. It is caused by a virus called human parvovirus B19. Another name of fifth disease is erythema infectiosum. It is a disease mainly common in late winter and spring season, and the symptoms are almost similar to a cold or a flu, but it is characterized by this rash, which might be there in some children. It is bright red, rosy rash on both the cheeks, which gives a characteristic slap cheek appearance. Some children might have joint pain, joint swelling, but it is mainly common in adults. Even though it is commonly seen in children, it impacts mainly pregnant women and their unborn babies. Some people who have problems with their immune system or weakened immune system, and also some people who have red blood cell disorders like sickle cell anemia or thalassemia can be affected more by that. Many times it does not require any treatment. It gets better by itself. Antibiotics do not work for this disease. Some children who have joint pain or high fever may require more supportive treatment. Sometimes it might be itchy. Most often it is asymptomatic. It lasts for about 7 to 10 days, and it is variable in intensity, and it goes away by itself. No need to put any topical cream or any steroid creams, because it is usually self-limiting. Parvovirus spreads through respiratory secretions, like in saliva, through nasal mucus, sputum, when an infected person coughs or sneezes. This parvovirus is mainly contagious when you seem like you have a cold before the appearance of a rash. After the appearance of rash, you are probably not contagious. Like any other viral infection, you can lower your chance of infection by washing the hands with soap and water often, by covering your nose and mouth when you cough or sneeze if you have an infection, by avoiding close contact with infected people. Keep a watch on fevers. If there is a fever of more than 104 degrees, give a call to the doctor.
Okay, so just a quick little video on Fifth's disease, kind of recap in a short manner what I just told you in all those slides. We're going to move on to selected infectious and communicable diseases in children. I have posted up some actual charts on these slides, and you probably need to print these in a full slide fashion so that you're able to see them. Either my printer was not very good, or they just didn't show up very good on the slides. I'm not sure which one, but we're going to run over those quickly. There are your learning outcomes. And we're going to talk about diphtheria to start with. So diphtheria occurs mostly in unimmunized or partially immunized children. For some reason, I cannot talk this afternoon. Maternal immunity lasts up to 6 months after birth. So it's very important that moms are actually immune to this disease. And I remember when we talked earlier in class about antepartum, we talked about MMR and whether or not moms were immune to different types of diseases. Diphtheria is one that we hope moms are still immune to as well, because it helps babies keep up immunity until they can actually get their vaccine. It's transmitted through contact and can also be transmitted through droplets for the pharyngeal part of this disease. And there's also a theory that unpasteurized milk can also serve as a vehicle to transmit diphtheria. Usually what we see is a low-grade fever with anorexia and malaise. These people typically tend to have a runny nose with foul odor, a cough, sore throat, hoarseness, and noisy breathing. And then they get these characteristic membranous lesions. And what we see is a thick, bluish, white to grayish black patch or patches that cover the tonsils. And those can spread to the soft and hard palates and the pharynx. So that's kind of a telltale sign for diphtheria, is that bluish white, grayish black patch that covers the tonsils or other parts of the mouth. Some of the complications we may see is that diphtheria can actually produce an endotoxin that will cause myocarditis and peripheral neuropathy, so we have to watch for that. If it gets very bad, we might see ascending paralysis that's similar to a Guillain-Barré syndrome. Therapy-wise, when it's suspected, we start antibiotics, and those should be initiated immediately. And usually what we give is a PNG or an erythromycin, and those are your broad spectrums. This is a vaccine-preventable disease, but a booster is needed every 10 years after that primary series. In terms of nursing management, we got to make sure we use droplet precautions and contact precautions. We want to suction gently if these people need suction, especially if they have that pharyngeal type. And gargling is not permitted for people with diphtheria. It can irritate the pharyngeal surfaces and make things worse. And another thing we do nursing-wise is encourage liquids. We're not going to spend any time on influenza. That's a pretty typical illness, and I'm going to let you read over that one on your own. But we are going to talk about measles, or rubeola is the other name for that. And this occurs in outbreaks in unimmunized children. It spreads through direct contact with droplets or through the airborne route. And maternal immunity for this disease typically lasts until the child is somewhere between 12 and 15 months of age. It's transmitted again through the airborne route or through respiratory droplets, and can also be transmitted through contact with infected people. There are some different phases for measles. The first one is that prodromal phase, and that lasts about 3 to 5 days. And during this phase, you will find that the patient has a high fever. They might have conjunctivitis. They may have a cough, anorexia, malaise. They may have Koplik spots, which are these bluish white spots, and they appear kind of on a red background, and you'll find them on the buccal mucosa. And then also there's a characteristic red blotchy maculopapular rash that will appear on the skin. So you can see in this little boy right here that red maculopapular rash he has on his face. That's a typical telltale sign of measles. And that usually appears 2 to 4 days after the onset of the prodromal phase, where they have that high fever and the cough and the anorexia. It begins on the face, and then it spreads to the trunk and the extremities. One of the major complications for measles is encephalitis and possibly death. Treatment for measles is typically supportive. There's no antiviral therapy that's available. We only use antibiotics for measles if there is some type of secondary bacterial infection going on, and this is a vaccine preventable disease. In terms of nursing management, if the child is hospitalized, then we have to maintain pretty strict airborne precautions. We can suction very gently if we need to. Remember, they have that rash on their buccal mucosa, so they tend to be pretty sensitive. We'll give antipyretics and antipuritics for the fever and the rash that typically itches. We want to assess their lungs very carefully, especially in young children, because sometimes these people get pneumonia as a common complication. We want to give them cough suppressants. Keep their skin clean and dry. Don't use soap on that rash. We may offer cool liquids in small amounts because that tends to help with those Koplik spots that tend to be painful. And also in terms of their diet, they'll get some type of blended or pureed diet that are easily tolerated, easy for them to swallow. So moving on to meningococcus. The highest rates of meningococcus typically occur in children under 2 years of age. African Americans and individuals that have a low socioeconomic status typically are at a higher risk to get meningococcus. Kids who attend child care centers, older adolescents who attend college, or adults that attend college and stay in the dorms, and adults that are in military recruitment camps also have a greater risk of contracting meningococcus. The transmission is through direct contact with droplet respiratory secretions. So these people have respiratory tract that's infected, and then if we come in direct contact with somewhere those droplets have landed, that's how it's spread. There's an abrupt onset of flu-like symptoms for these people. And then with your neurological meningitis, you find that they have severe drowsiness, they may become disoriented, they might have hallucinations or even seizures. You often find urticarial maculopapular or petechial-like rash, and that progresses. And sometimes you may find complications of shock, hypotension, or even DIC in these people, and it can progress to the point of coma and even death. They might end up with some type of necrosis and have to have loss of digits. They may have hearing loss, arthritis, myocarditis, possibly seizures, or different types of cranial nerve palsies can occur in individuals, especially with this neurological meningitis. And you can see a picture of the rash that has that maculopapular rash that has progressed to a purpura. We treat this with PenG, and we give that IV. It's not an oral type treatment. They will get this intravenously. And we hope that we're able to catch it quickly and treat it fast so it does not progress to those complications, because as you can see, they're severe. For the child, we manage it very aggressively, and we manage it in the ICU so that we can maintain their airway and assist with ventilation and manage shock if we have to. There is a vaccine for adolescents, but you have to be at least 11 years old or older to receive it. So it's very important to educate parents on the vaccine once their child hits that age, but also to educate them on ways to prevent this illness prior to then. Close contacts with people who've been exposed or people who have been diagnosed are also given medication. And healthcare workers that have been exposed to oral secretions need prophylactic medication as well. For these children, we use standard precautions and droplet precautions until the antibiotic therapy has been administered for at least 24 hours. And the disease onset is very abrupt and it very rapidly progresses. So it's important to catch it early so that we don't end up with those complications like seizures, cranial nerve palsies, coma. Moving on to mononucleosis. This is another fairly common illness that we find in children. Sometimes we see this in adolescents as well. And you might have heard this called the kissing disease. It's caused by the Epstein-Barr virus, and that's part of the herpes group. It's spread through direct contact with infected oropharyngeal and genital tract secretions, which is why you typically see it in adolescents, your teenagers. But in very young children, it can cause irritability, and possibly a maculopapular rash in a few cases, but otherwise it's usually asymptomatic in really young kids. In older children, it's characterized mainly by malaise, fatigue, headaches, anorexia, abdominal pain. They may have a fever that lasts just 2 or 3 days. They might have swollen lymph nodes and a sore throat, so you may hear them complain about that. But the biggest thing is that these people are just exhausted. They are totally fatigued. The whole syndrome typically lasts somewhere between 2 and 3 weeks, and it's self-limited. So there's not a lot that we do in terms of medication. We just give supportive treatment. Complications are usually rare, but if they occur, you may see encephalitis or aseptic meningitis. The virus, once it's contracted, it's there, and it will usually lay latent. And then periods of stress can actually reactivate this virus. There is not any really known prevention in terms of a vaccine or anything. Just, like you do for any other infection, good hand hygiene, try to avoid contact with people's secretions. In terms of nursing management, it's treated at home. Standard precautions is all that's needed. We may give antipyretics or analgesics to help with, they may have those, body aches or the abdominal pain. Bed rest is big to take care of the fatigue. And for teenagers, they really should avoid kissing their boyfriends or girlfriends or anybody until their fever has been gone for several days, because they can transmit it to others, which is why you might hear it called the kissing disease. The next illness we're going to talk about is whooping cough, or pertussis. And those of you who have paid attention in class might have remembered me talking about pertussis or whooping cough in relation to newborns or moms that need to be vaccinated before they go home with the Tdap. And this is the most common in children under 6 months of age. Pertussis immunity may last for up to 10 years following their immunization, but there is a concern about the diminishing efficacy of the vaccine. So that's why we always get a titer on our pregnant moms now to see if they have had Tdap. Not a titer, but we always get a history as to whether they have actually had the Tdap vaccine and when was the last time they had it. Because our babies can't get this vaccine for several weeks after birth. So we want to be sure that anybody who is going to be around them has been vaccinated and is actually immune so they don't transmit it to the baby. It's spread through respiratory droplets and direct contact with discharge from the respiratory membranes. And it has several different stages. There's a catarrhal stage where we have nasal congestion and a runny nose. You might have a low-grade fever, and we have a non-productive cough. And that lasts about 2 weeks. And then the disease moves on into the paroxysmal stage, where the cough becomes more severe. And typically you find that it's more severe at night. We have this forceful inspiration that happens, and because the glottis becomes narrowed, we have stridor and this whooping sound, which is why it's nicknamed whooping cough. Young infants, so babies, may actually exhibit longer periods of apnea instead of the whooping cough. So that's something to be aware of. And then it moves on into the convalescent stage, and that can last up to 6 weeks. And that just is when things kind of start to clear up. It's when the paroxysmal stage gradually starts to subside. Complications related with whooping cough include pneumonia, otitis media, encephalopathy, seizures, and for newborns and young infants, death is also a complication that can occur. We treat whooping cough or pertussis with macrolide antibiotics, and we give supportive care. It's most severe in infants that are under a year old, and that's where the most of the deaths occur, like I just said. And this is a vaccine-preventable disease. Although newborns and infants cannot get this vaccine for a few weeks after birth, because of the high rate of deaths that occur in under a year, this is why many OBs and the maternal community has started looking at really ramping up vaccines for moms and dads and family members of people who have had a new baby. In terms of nursing management, you have to remember to use droplet precautions for at least 5 to 7 days after the antibiotics have been initiated. These people need to be on a cardiac monitor and a pulse ox so we can continually assess their respiratory system. And the smaller the child, the greater the risk for respiratory distress. We just finished up individual module 6 in relation to newborns, and we know how quickly they can go into respiratory distress. So it's very important to keep a close eye on them and continuously monitor their respiratory system if they have this illness. If the child has a coughing spell, it's very important that you remain with them until that coughing spell is over. We give antipyretics for their fever. We encourage frequent rest periods, and we encourage fluids for these people. Pneumococcal infection. I'm going to allow you to read over that one on your own. And we're going to move over to the next one. Actually, we're going to move over down to roseola. So roseola is primarily diagnosed in children between 6 and 24 months of age. And most likely it's transmitted from respiratory secretions. These kids tend to have a really sudden high fever, so almost 105 degrees Fahrenheit, for several days, 3 to 8 days. It's characterized by a pale pink, discrete maculopapular rash, and it starts on the trunk and spreads to the face and the neck and the extremities. These kids often can have complications of febrile seizures because of that sudden high fever that they typically get initially. And they can also experience encephalopathy in rare cases. Roseola is a self-limiting disease, so we don't really treat this with drugs in terms of antibiotics or anything like that. We treat supportively. Nursing management wise, we make sure to use standard precautions. We give them antipyretics and we keep a really close eye on their temperature so that we don't end up with the complication of febrile seizures. And we encourage fluids because we know that fever puts us at risk for dehydration, especially in children who can get dehydrated very quickly. The other name for roseola that you might hear is called sixth disease. Rotavirus. Many of you actually may have seen this in your clinical rotations in the pediatric units. This is a pretty common illness that occurs in the late fall and the early spring, and it is a diarrheal epidemic. So you will end up, if you have one kid who comes in with rotavirus in the hospital, you will typically see several more that are admitted with the same rotavirus. It is the most common cause of severe diarrhea in children under 5 years of age, and it's transmitted through the fecal-oral route, if you could not guess. It has an acute onset. You will typically see a low-grade fever and vomiting, and then 1 to 2 days later, these children end up with a severe watery diarrhea. They may have a stool 10 to 20 times a day, and that can last anywhere from 3 to 8 days. So they are at very high risk to become dehydrated and have electrolyte balances. Treatment involves adequate fluid and electrolyte replacement. We have to introduce a regular diet within a few hours of rehydrating the patients because that tends to shorten the duration of the disease. So we want this to be as limited as possible. We don't want somebody having 10 to 20 diarrheal stools that last for 8 days long. If we can reintroduce food as soon as we've rehydrated them, then we can limit the number of days that they're going to actually experience this illness. So that's important. A new vaccine has been approved for infants. So most of your babies these days actually get a rotavirus vaccine. In terms of nursing management, we have to use standard and contact precautions because this is a fecal-oral route transmission. We want to encourage hand hygiene with soap and water. So almost just like your C. diff, we want to encourage the soap and water for this type of virus. And it will actually remove 75% of the virus from hands if we use soap and water. So we want to follow up with an alcohol-based hand sanitizer after washing with soap and water so that we can increase the effectiveness of our hand hygiene. And above all else, we have to keep a really close eye on the hydration status for these patients. Okay, rubella or German measles. This is also a virus that can be contracted by newborns, and the maternal antibodies will disappear in those newborns between around, or in infants around 6 to 9 months after birth. So this is part of that MMR that we talked about earlier, the MMR vaccine. For mothers who actually contract rubella or German measles during their pregnancy, those newborns can be born with something called congenital rubella syndrome. And the risk for that is very high if mom has never been vaccinated or is either non-immune. It's transmitted through droplet spread or direct contact with infected people. And it can also be transmitted if you end up with contact with some type of article that is soiled with respiratory droplets or nasal secretions. There is a characteristic pink, non-confluent maculopapular rash that appears on the face, and it progresses to the neck and the trunk and the legs. So it will start at the head and move towards the feet, and it actually will disappear in that same order. There are different stages for this, and the prodromal symptoms will be a low-grade fever, headache, malaise, and a sore throat. And then you get these Forchheimer spots, which is that erythemus pinpoint rash that happens on the soft palate. And then after that, we may see this rash on the body. For neonates specifically, whenever we're talking about the congenital rubella syndrome, it's important to remember that some of the signs of this are growth retardation. They may end up with a specific type of bone disease. They may have an enlarged liver or spleen, thrombocytopenia, and then they have these purpuric skin lesions, giving them a blueberry muffin appearance. And that is a telltale sign of congenital rubella syndrome in a neonate, is this blueberry muffin look. Complications are related mainly to arthritis in adolescents and encephalitis. Treatment is supportive because rubella is generally self-limiting in children. The major risks with this disease happens to be for the fetus if the mother is infected in the first trimester, because that's when we start to see this congenital rubella syndrome. And oftentimes it's associated with eye problems, cardiac problems, auditory, and neurological problems. Rubella is a vaccine preventable disease, which is one reason why we stress MMR for pregnant ladies after delivery, because remember, this is a live vaccine, so pregnant ladies cannot get this during their pregnancy, but if they're immune or they're equivocal, then we highly encourage them to get this after the baby is born. In terms of nursing management, we have to maintain standard and droplet precautions for children who are contagious. And if we have a newborn who has been diagnosed with congenital rubella syndrome, we have to maintain contact precautions for at least a year or until their nasopharyngeal and urine cultures are negative after 3 months of age. And that's a repetitive test that gets done. So they have to be negative several times. Children definitely need to be isolated from pregnant women just because of the risk of transmitting this illness to a pregnant woman and causing congenital rubella syndrome for her unborn child. And then supportively, we just give pain meds or analgesics and antipyretics for fever. We're going to move through streptococcus and tetanus. And we're going to talk about some of the clinical manifestations of infection in infants and children because it can be different. So here are your learning outcomes. And this table is posted here and broken down into systems for you. It'd be good if you look over these just so that you can distinguish the different types of clinical manifestations of infection for infants and older children. So in terms of the central nervous system for infants, we tend to see irritability in both infants and children. But in children, we may see combativeness. For infants, we might see a bulging anterior fontanelle, which tells you that there is some pressure there that should not be there. Babies tend to have a high-pitched cry and muscle weakness. You may see seizures or subtle changes in their muscle tone. So they become hypotonic. Remember, we like our infants to be somewhat moderately flexed. So if you start seeing changes in muscle tone in terms of them becoming, their extremities becoming extended or hypotonic, that is a sign that they may have infection. For older children, they may complain of a stiff neck or back pain, and then you'd start thinking meningitis. They might complain of photophobia. Brudzinski's sign is actually when their hips and their knees flex up whenever you flex their neck down. So if we flex their neck to their chest, then we see their hips and their knees will flex up at the same time. And Brudzinski's sign is a telltale sign of meningitis, along with Koenig's sign. Koenig's sign is an inability to straighten your leg when your hip is flexed at 90 degrees. So if we flex somebody's hip up to 90 degrees and they can't extend at the knee and straighten their leg out, that's Koenig's sign, and that's also a telltale sign of meningitis. In terms of the cardiac system or the cardiovascular system, for both infants and children, you may see pallor, but in infants, it's typical for you to see mottled skin, and in children, you might see flushed or dry skin. For infants, some additional signs would be cyanosis, hypotension, and bradycardia. Moving on to the respiratory system. For babies, we talked about this in individual module 6. We see signs of respiratory distress whenever our babies start exhibiting retractions, nasal flaring, and grunting. And then we know that infants typically have apnea, and that's normal as long as it's not longer than 15 seconds. But if their apnea has a new onset, or they're having increased episodes of apnea, or their apnea is lasting longer than it should, that's a sign of infection. In children, we don't typically see the grunting. You may see the retractions, and you might see the nasal flaring. And then sometimes you may see stridor or hear stridor. For the GI system, specifically in infants, we'll see poor feeding. We'll see abdominal wall discoloration possibly, and maybe even jaundice. For children, poor appetite, or they may have abdominal distension, and these kids may actually complain of stomach pain. For the renal system, in infants, we might see a decreased urinary output. Specifically, if they have some type of urinary tract infection, we all know there's going to be white blood cells in the urine for children and infants or anyone. But additional signs that you might see in your baby is a decreased urinary output. For their hematopoietic system, in babies, we might see a fraction of band cells, or you might see increased immature white blood cells, which are your bands, if the infection is caused by bacteria. Same thing with children. For the metabolic system, in children, you may see hyperthermia, so a fever. They might end up with chills. And then eventually, if they run into septic shock, you're going to see them become hypothermic. Remember when we talked in IM6 about thermoregulation and infection for infants, we said that typically hyperthermia is not your first sign of infection in a newborn or a young infant. Typically what you're going to see first is that hypothermia, and then it may progress to hyperthermia. And then also in infants, you may see hypoglycemia or possibly hyperglycemia, so one or the other. So review this table a little more in depth, but I've given you sort of the main points there in terms of clinical manifestations of infection. And that is the end of individual module 9 in relation to infection.